Good afternoon and welcome back to HealthLeaders, the Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Jay Asser. I'm the CEO editor for HealthLeaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Transforming Through M&A. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details that we need to go over. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website at healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right corner of your screen. Here we have listed the webinar slide deck for you to download. Additionally, you will find a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it's my pleasure to introduce our panelists for today. We have Ed Banos, CEO from University Health, and Matthew Heywood, CEO of Aspirus Health. Thank you both for joining us today. Before we jump into our discussion, it would be great if each of you could tell us a little bit more about yourselves and the organization. Matt, why don't you kick us off?
Thank you for having me today. My name's Matt Heywood. I am with Aspirus Health. I'm president and CEO. I've been here for 13 years, and I've been in healthcare for about 30 to 35 years. Aspirus Health is 18 hospitals. It is 130 outpatient sites, 14,000 employees, and about 1,300 employed physicians and APCs, and we cover about 50,000 square miles over the states of Michigan, Wisconsin, and Minnesota.
Great. And Ed, why don't you tell us a little bit about yourself as well?
Hi, I'm Ed Banos. I'm the CEO at University Health. I've been in this role of 6 months. Prior to that, I was the chief operating officer of the system for about 10 years. We are the public health system. Our real name is Bexar County Hospital District. So we are the hospital district for Bexar County, Texas, which includes San Antonio. Currently, we are a 2-hospital system on the same campus. We're currently constructing 2 community hospitals. We're licensed for 1,254 beds. We have about 12,000 employees. We are a level 1 pediatric and adult trauma and also a teaching hospital with the University of Texas, San Antonio, and also with the University of Incarnate Word. We have a large physician practice with 30 locations throughout the South Texas area. And then we also have an insurance plan that does about $1 billion in revenue and has about 200,000 covered lives.
Great. Thank you both for joining us today to talk about M&A. Of course, this is an important topic right now in healthcare and for hospitals and health systems as they pursue deal making. Health systems can pursue integration and have incremental changes to improve certain areas of their organization, but to really thrive, they need access to care, to expand access to care and services by reaching as many people as possible. And when strategized correctly, M&A can remedy that lack of capital and resources and allow systems to reach their full potential. So first off, as we put 2024 in the rearview mirror and now are in this new year, I want to start by asking both of you, what are some of the current M&A trends that are shaping deal making right now, and how do you envision them evolving? Ed, why don't you kick us off on this?
Well, here in South Texas, most of the mergers and acquisitions have been not hospitals, but freestanding emergency rooms, ambulatory surgery centers, physician practices. we've seen a lot of the for-profit or private equity money start to get out of some of the business here in San Antonio. A big group for us that we've taken on lately is with pediatrics, a group that runs a lot of pediatric specialties. They've decided to get out of the San Antonio market, so we've acquired their pediatric cardiology and pediatric ENT services. So we don't, in San Antonio and South Texas, with the growth of the population here, we don't see a lot of hospitals being bought and sold. The two main competitors in town are Tenet and HCA, so they are continuing to expand their for-profit practice. But we don't have a lot of mergers and acquisitions. We're about a 4-hospital system, but most of our mergers and acquisition are going after the ambulatory services and also the physician practices.
Matt, I'll throw it to you for the same question.
If I could, I think some of the questions we're going to have today are going to require some context, at least from our perspective at Aspirus. So if I could, for a split second, maybe talk a little bit about the context of the environment and how we think it's changed recently. That is, I think, influencing the mergers and acquisitions as we go forward. So in our view, the environment is going to be significantly different than it has been historically for the last 20 to 30 years in healthcare. I would consider the last 20 or 30 years, since 1990 pretty much, the environment would be what we call a moderation era. It's an era where we had a lot of outsourcing, we had a lot of low inflation, and other than 2008, when we had the major housing crisis, it was very shallow recessions with moderate growth. In that world, healthcare grew up after the in 1984, 1985, when the federal government gave us fixed rate DRGs. We grew up during this environment of fixed rate DRGs and the conversion of more commercial to Medicare as our populations aged in what I would call a moderate era, a relatively stable era, where we had low inflation and we could get moderate cost increases from our commercial side, even though it was shrinking, and we could try to become cost effective in this environment with Medicare as it continuously reduces its payments to us. I think, and our company thinks, it's going to go back to what we call the more tumultuous era, is post 1940 something, after World War II, and up until 1990, where you had a lot more inflation spikes, you had a lot more spikes with recessions. And in that more volatile environment, we are really concerned about the cost structure and the revenue structure of healthcare and how it's misaligned to this new environment. And so when you start looking at that misalignment and you realize that you're going to not easily get through high inflationary spikes, you're not going to get through challenges with our supply chain that are now starting to pop up. We're seeing that we have cybersecurity risks that we never had before. Even in the tumultuous era of 1945 to 1990, they didn't have cybersecurity events like we're going to be having today. And we have to be prepared for. We have the labor is becoming far more active than it was in the last 30 years. So we're seeing a lot more what we call business adversity risks on top of these potential inflationary and potential recessionary volatility. So in that environment, you got to really assess, what do you think your core competency is? And is that core competency going to be strong enough to get you through this new environment? And then the question after that is, are there potential merger opportunities, be it in the inpatient, outpatient side, that can help you get through this future state? And can you use your strength to take those acquisitions and make them valuable? And when you do that, you can then start to assess some of these questions that we're talking about today. So now, under that environment, when we look at a merger and acquisition opportunity, we're really looking at the merger opportunity from the perspective of, we know what our secret capability or sauce is, as we call it. We know what value we can bring. Does this organization we're talking to add to it? Does it have some additional elements that we need to further develop ourselves? Or is it an environment or an organization that needs what we have, and we can illustrate that we have that value we could bring to them, and we can go and make something better than what they currently have. So we look at organizations from that perspective. And I think we're starting to think beyond just what's accretive to our local market and saying, do you jump into another market if that market has an ability for you to achieve your strategic goals? And you're starting to see that nationally a little bit more, where some systems are not just thinking contiguously to their existing market, they might jump to a whole nother state and look at another state. And so I believe in the environment that we're looking at, we are very selective in our acquisition opportunities, and we are very clear on what we could bring to the table when we look and talk to a partner.
That's great context. Thank you for adding that, Matt. Ed, I want to go back to something you had talked about and touched on as well, as far as pursuing M&A on the outpatient side. That seems to be a very popular strategy right now. Where is the value in that right now? Why is it something a lot of organizations are pursuing, and how can you reach new markets through the outpatient, investing in outpatient services?
Yeah, well, I think for us, we're a hospital system that is very busy. Our hospitals are full every day. And because we're a public hospital and we're not necessarily driven by a true, like a for-profit or some others that have to have a certain margin, for us, we have about 25% of our patients are uninsured, and we're obligated to take care of the uninsured through the county. For us, we know that, as was mentioned earlier, driving the costs down is very, very important. And when you can treat a patient in an ambulatory setting, or even through population health and public health, you can try and manage illness and well-beings before it becomes an acute issue. We know that in the long run will prevent high-cost admissions. For sure on your underinsured or uninsured. So we see the ambulatory strategy of one, that we can go and try and address the illness early. Two, through our public health entities and others, we can start changing the dynamics in the community. There are parts of San Antonio that are healthcare deserts. They don't, for as big as San Antonio is and as large as the community is, we're the only clinics in that area. And we know that for us to grow and expand, it's very hard to go hiring doctors one or two at a time when you might be able to acquire a practice or an ambulatory setting, or say a freestanding emergency room. We also look at the high volume or high value networks. We look at working with managed Medicare and managed Medicaid, which is very popular here in Texas, being able to go at risk with those insurance companies, with our own insurance plan, how we can drive down healthcare costs and get incentives from the insurance companies. So we believe the long strategy is the hospitals will always be here for taking care of the acute injury, but we believe that an ambulatory strategy with high quality doctors and clinics located closer to where people live and work, we believe that this will help drive down the cost of healthcare by treating it early.
Great. And Matt, is there anything you'd like to add on that side, on the outpatient side?
Only thing I would add is, interesting, when I first took this job back in 2013, we were designed heavily outpatient already. We were like 70% to 75% of our revenue is outpatient. So we were already heavily kind of outpatient structure, but being more rural, your outpatient setting has got to be tied to sometimes a critical access hospital or to another site of care so you could be most efficient. So we're kind of taking our outpatient strategy and blending it with our hospital strategy, given our rural nature and the amount of square miles we cover. And I think the other real surprise that we're finding, and I think it was just mentioned previously, is we're actually surprised. The literature would have said years ago that we're going to need less beds in our various communities. And I think we're starting to find as an industry that may or may not be the case, depending on your market, and that the industry's been shrinking its bed capacity for years. And I think we're finding that you actually, at least in our market, are going to need certain higher acuity capacity. and we're actually finding we're having to expand our acute care capacity for our tertiary centers. We have 2 of them, and we got to get them actually bigger to deal with the aging population and the severity of those illnesses that can't be managed by some outpatient setting. So it was a little surprise for us as we were heavily for years pushing to the outpatient market, as everybody's talked about. And now we're like finding that the aging population is starting to overwhelm people's perspectives of how many beds are needed. And we're actually having to try to catch up on that.
That's interesting. Yeah, I think as you both touched on, ambulatory care is going to be a major theme in this coming year for M&A. Matt, you had touched on how organizations can view M&A partners, identify M&A partners. So I want to ask both of you now how leaders can assess their own organization when they're considering M&A. What are some of the steps that you take to pursue a deal, to consider whether you should be pursuing a deal? Take us through that process, Ed. I'll start with you.
Well, the first thing we want it to be is we want to make sure that it fits into our mission and our core. When we look in there are a lot of times we get approached by, some type of service or center, and it's really not part of what we really feel is part of our mission or our core. When we do look at our senior leadership, looking at how do we spent a few years ago putting together strategic plans of, we have a pre-acute strategy, an acute strategy, and what we call a post-acute strategy. And each one of those leaders are looking at how we can manage the patient or the population through that complete continuum. On the pre-acute strategy, it's certainly the ambulatory practices, the maybe freestanding emergency rooms, those types of things, the hospitals. And then the post-acute strategy, we're looking at LTACs or skilled nursing facilities, even assisted living type of structures and the others. So if something would pop up that would become part of, that would fit into that initial strategy of one of those 3 pillars, we would look at that and then also make sure that it meets the criteria of what we want to do from a high value network. When we look at our nursing homes, we look at what type of nursing homes, what types of patients they see, where they're providing that care. So we want to make sure that it helps us provide either a continuation of care or something that's a value added service. An example for one thing that we're doing right now, we do a lot of transplants, livers, lungs, kidney transplants. And a lot of those patients need to stay within location of the hospital. So we look at housing locations where we can keep those patients, because many patients will be coming from all over the state of Texas for our organization. So something strategic we would be looking at is where we have diagnostics, but also housing for these patients that might have to stay for a month or 2 while they're getting either assessed or post-transplant. So we really look at those assessments to make sure that it fits in the 3 pillars, but then once we identify that they meet the mission, the vision, the values of the organizations, because just buying something that provides a service but doesn't necessarily see the value of integrating within your organization, I think would have a lot of disruption for us. So we're very, very careful when we look at a practice or look at an opportunity. It's not nearly just, hey, this is a practice in town that all 3 organizations that are competing with us might want. There's ones we've looked at and said, we're not really interested. Thank you very much. Even though we might need that service, it's just not a strategic fit from the culture of the organization.
And Matt, from your perspective, whether speaking specifically for Aspirus Health or just in generally, how can leaders assess that M&A value for their organization?
I would say I will just speak from our perspective, and it'll maybe carry over to a broader perspective. But from our perspective, I think the first question that we had is, at first we were an amalgamation of parts that we came together, and then it was very obvious that there were certain accretive or partnering organizations that would fit in. We called it tuck-in with our existing organization when I first started. After we got to that point, and over these last 10 years or so of my 13, we really started to form the company's culture and became one organization from the bottom up. And everybody starts to think of themselves as Aspirus. When I first was here, we had a lot of independent hospitals that were like a holding company. And that was where healthcare has sometimes been for quite a bit of time, calling themselves systems when they're really just holding companies. So to become an integrated company, we created what we felt made Aspirus Aspirus. So now that we've done the obvious acquisitions or mergers in the last few years, before we partnered with St. Luke's up in Minnesota, the question I asked the team was, so you now are Aspirus. What does Aspirus mean to you? What do you think makes you Aspirus unique? And what values do you think we can bring to another organization? And then we will go out and look at potential partners going forward based on that. And so when we started thinking about what makes Aspirus good and great is that we have very rigorous, tight, integrated board all the way down to operational structures and processes. We've worked very hard for 13 years on truly integrating in a very rigorous, structured way. And we're really, I think the team's proud of what it's able to accomplish and what it's able to do. And so I said, if that's our strength, what organizations do we then see out there that might need that capability? And how do we show them that capability? And so with St. Luke's, we identified them as a potential, I think, growth plate for us to move into Minnesota. They were contiguous. That gave us a great opportunity. And then we saw that they had value there that wasn't being tapped because we had some of those skills and capabilities that they weren't able to fully utilize given their certain situations. So we saw the ability to take what we thought made us good. We went out and looked around in the market around us and looked for partners who might need that skill and saw value to that skill and would want to join and partner with us. And I think we're going to continue in that mindset. And we have a project discovery, as we call it, where we're continuously looking out amongst the field, both contiguous and not contiguous, and asking what key attributes are we looking for, and do we believe our key attributes can add value to that? And there's been a number of times where we said, nope, we don't think that those two match up and we're going to pass. And there's a few times where we said, yep, we think that we could add that value and it makes sense. So that's how we go about it from our perspective. And I think it helps also us make decisions, but it also helps others when we're talking to them to see the value of partnering with us or choosing not to, depending on the value that they see in what we bring.
And of course, we know the work is kind of continuous when you're going through a merger, pursuing a merger. It doesn't really end after a deal is closed. Post-merger, you have to go through steps to integrate systems, hospitals, cultures, operations, all that. So I want to ask, what are those steps, and how can you do those steps efficiently post-merger? We'll start, Matt. Why don't you kick us off this time?
Okay, thanks. I would say the first thing that we're really finding that's interesting is you got to make sure that the person or the organization you're talking with sees a common understanding of the environment. And that may sound kind of trite, but the reality is if somebody thinks this environment is going back to what it's been in the past, and they go back to the view that it's going to be the moderation era, as I call it, and we view the coming era as becoming more tumultuous, we see a different future than that other entity or person. It makes it hard to have a foundation for an integration, let alone a partnership. Because if you don't see that commonality, you won't be willing to do some of the next steps we're going to talk about. So the first thing is we got to make sure there's a common understanding of the environment. Then we have to make sure there's a common understanding of the skills needed for success in that environment. And third, we have to agree on the desire to drive to that strategy and that value. And then in that environment, number four, you want to communicate effectively the why, the reasons, and be very transparent about it. And if you do that, then you're not getting into a merger or acquisition partnership that is not built on the common foundation. Is we might have similar beliefs, but if you don't have similar understanding of the environment, you don't know what strategic values you could bring, you aren't willing to drive to them and make the tough choices, then you're not ready to be able to get the value out of the merger and truly integrate. And as we talked about, you can't be a holding company today. You got to be a truly integrated healthcare system if you want to survive in this tumultuous era. And so you got to start from that foundation and go through those steps as I talked about. And St. Luke's, I think, is a great example, is we were very clear on that with them. We were very transparent. Even with all that, their board and their organization struggles. They struggle with the emotion, the amount of change, but they're more understanding of it and we're willing to do it. And in a matter of, we've merged 3 months, March of last year. And by April of this year, we will have them on Epic, Infor. They're already merged into the organization and they're pretty much about 70 to 80% integrated into our company by this March or April. And to do that rapidly, you got to have all those commonalities. And even with all that work, they still have struggled a little bit because of the pace, the speed, and the amount of change. So that's kind of how we're approaching it. And it's been pretty successful for us. When we did it with the Ascension acquisition, we acquired a number of hospitals from Ascension in 2021. We've integrated those hospitals, and since integration, we got them on Epic, got them in our systems in 6 months. And since 21, we got them into 21. From 22 until today, we've doubled their revenue and turned them from not profitable to profitable and improved their quality significantly and their service significantly in a matter of 2 years. So that speed of integration is very much foundational to success, but you got to have all those other steps to get there.
Ed, I'll turn it over to you as well. What are some of those steps that you really identify post-merger?
Yeah, and I think Matt hit on a lot of them, but I'll speak to our side a little bit. Is since we're not we haven't really gone after and acquired major systems as Matt and Aspirus has done. I mean, there was a local hospital in town that ended up closing that looked at us and looked at the other hospitals as an organization. And I will tell you, the simple way of first making that first step is you sit down with the leaderships at both sides, many times over a dinner or some type of meeting where you sit down and you just get to know each other. And 90% of the time, your gut will tell you if this is a deal that you're going to be able to move forward on, or if this is a deal that you need to walk away from. I've done it in my career, in other systems that I've worked with that I have been acquired, and I've also been one of the acquiring hospitals that have set that up. But what I've learned from my past and also here in some of the smaller things that we've acquired is when you sit down and you really lay everything on the table and what it's going to be. I mean, most people think that mergers are going to be mergers. Sometimes mergers are ownership and they're takeovers. And if you have somebody that you're acquiring, as Matt mentioned, might be a hospital that's not doing well, and you're going to take them over and you're going to do it, you need to integrate that culture and have that understanding. But many times if people on the other side think, though, this is a partnership, we're going to do this, then immediately you're going to have friction. So I think setting the expectations up front, many times when we've done some acquisitions of we've dialysis centers we've taken over here and others from organizations out of Nashville and other places where they're not local to us. It's a true transactional interaction with the organization that's outside of the state. But what you're also doing is you're working with and acquiring those people who are local San Antonians who live in the town, who are part of the service, who are caught up in an acquisition. So it's very important that you know who you're dealing with the individuals who will be the day-to-day operators, and how you integrate with the culture of the organization is a lot different than, say, an owner who is just getting out of the business and selling assets and a corporation or a company name. So I think it's very, very important that at the very beginning of the integration, you do set the standards and expectations, and set that even before the closing documents are due, because you don't want to have any misunderstandings or people who are thinking something is going to be different when your staff go in to try and work on the transitions of integrating it together. Again, I agree with Matt. When we've integrated, but we've also been able to add things like Epic and the others where they see there's opportunities where there's improvement. Many systems don't have a great IT system, and you can rally around Epic and the great operational opportunities you have in Epic. And then you can also, with University Health and what we've been able to do in the community from a standpoint of seen as one of the most preferred healthcare organizations in San Antonio, I think that culture, people want to be a part of that, and they want to see that organization be part of a teaching organization and be part of an organization that is going to be able to provide service for everybody, and we're very mission driven and have that. So it starts off setting the expectations very early on, that you know what you're getting into. Now, that's not to say that afterwards there's not going to be some bumps in the road or how things are being operated. But what I've seen lately is a very big understanding, memorandum of understanding and document that we try and spell out as much as we can of what is going to happen, how it's going to happen, and what the expectations are. And that could go down to what our volume is expected to be, what our staffing plans are expected to be. So nobody comes into this with the understanding of one thing, and when the organization does do the acquisition, it's different. So I think starting the cultural change early, understanding that a lot of work goes into those months of town hall meetings, meeting with the staff, doing what you can to make sure they understand what the expectations are, what the organization is looking to do, how they fit into the strategic plan, so that they can see that they are part, for us, for University Health, that they are part of University Health. They are not just, some other little company that's on the side or another service. They are truly going to be integrated into the system. Those are the things we see that keep the staff retained, keep the organization moving forward, and then getting that to really be part of our system total integration.
Yeah, and Ed, you mentioned the mission, and at the end of the day, the mission is always going to be taking care of patients, and that's something organizations can't afford to lose sight of when they're pursuing these mergers. Of course, M&A is kind of vital, especially right now, to the financial health of many organizations. But how do you balance that need for financial stability with serving your community, serving those patients, and ensuring that there's not negative consequences on the patient care side? Matt, again, I'll kick it to you first.
I would say the first thing that is the foundation of my thinking is a statement that I heard a speaker say at one of the conferences that we held for our board retreat. And I'll paraphrase them, but it was along the lines of, a good, well-run organization mitigates the challenges and the impacts of the world that I just described in this tumultuous era for their communities. A poorly run and a poorly managed and a poorly financial healthcare system actually amplifies those community challenges of the environment I'm talking about. So what I mean by that is, if we go into a recession, or if we have high inflation, or if we have labor strife, or we have challenges in our country, if the health system isn't a strong, vibrant health system, it actually makes it worse for their communities because it's not strong enough to absorb those challenges. A well-run healthcare system absorbs some of those challenges, and their communities are thriving and they get through it. There are community members in some of our communities. We're the biggest employer. If we are not thriving and surviving, then our communities aren't. So I think the first thing that our organization realizes after we heard that statement, and it kind of ties to our culture and our norms, is we got to have a well-run organization. And that means well-run means we have high quality, high service, and are financially viable, and we're consistently a top 25 health system in all of those categories. Are there areas we're not? Yes, but on average, all those areas, our goal is to be top 25 for every one of our sites, and we are doing a darn good job of achieving that. So that is our overarching goal. But to do that, to help us and to help our communities, you're going to have to make tough choices in this world. You're not getting enough OB-GYNs produced. You're not getting enough certain subspecialties produced. You're going to have to make tough choices and maximize your model and maximize your sites of care to ensure our patients and our communities have access to services. But sometimes you're going to have to make some tough choices in order to achieve that. And they're going to have to drive a little more, maybe, in some instances, or use teleservices in some instances. So in our organization, our motto is to be a strong, vibrant organization first and foremost. Then, if that means we make tough choices, we need to make tough choices, and we need to make sure that our services are there for our community. They just may have to be there sometimes in a different location or in a different manner. And that's kind of been, I think, our motto to get through some of these tough environmental challenges and serve our communities and be financially and operationally prudent.
Ed, same question. How do you navigate that balancing act?
Right. I think, and Matt hit it on the head on this one as well. I mean, when you talk about an organization, you always lead by quality. If you're always a quality organization, that, quality doesn't automatically give you a positive bottom line, but it gives you a very strong foundation of which to build. And when we look at financial stability, when you look at the metrics that you need to be looking at, from either a Leapfrog A or your Medicare, star ratings, to the things that you measure yourselves externally as well as internally, there are hard decisions every day, because you have to make decisions between, it's not the decision between a good and a bad decision, but it's a decision between the two goods you have to make a choice for, because you only have dollars for one of the two goods. It's very easy to say, oh, this is the better deal than the bad deal. But when you have two good opportunities that come up in front of you, it is something that you have to look at, and it's a hard decision sometimes to make the decision between the two goods. But, as an organization, financial stability, has to be the first thing that you make sure of, because if you're not financially stable, you're going to make sure you provide high quality. But if that's not producing the bottom line, you're really going to have to make some hard decisions to say, now, how do we make sure that we can do that? I think in healthcare today, you don't want to put all of your eggs in one basket. We're a state that didn't expand Medicaid. So we got supplemental funding programs. We've got pay for performance programs with the state and with the feds. We have our own, commercial contracts. We have our, opportunities to take care of disproportionate shares. So you've got other fundings from the federal government. So we don't ever want to put our organization put too much in one bucket, where if that bucket would drive from a governor's signature or a federal government change, you don't want to go out there. But we spend a lot of times looking at how can we best implement programs where there's funding. We've implemented hospital at home here and grown that business now for a few years, that have really decompressed a lot of patients that don't need to be in the hospital but still are sick enough that they need some care. We've looked at other types of programs to make sure that we can diversify. And those are the things when you look at that. And again, when you're looking at a merger and acquisition, it's, what is the business that they can bring you that is going to help fund some of the uninsured commitments that we have as a public institution, so that you have to, make money on the good so that you can help pay for the underinsured. But also, where can you grow that market share and others, where then you can have some ability to negotiate either carve outs or special payments that will either help you from a supplemental funding program or with an individual commercial provider, where you could be seen as a center of excellence, say in our transplant programs, where we can get additional funding. And then we've implemented also where we can be an organ retrieval center. We implemented a center for life where we can do those things to help pay for the organ retrievals by doing them over in our organization and having those patients transferred to us. So we look at all alternatives that we can to help. And every one of those, you have a winner, you have a loser, and then you try and balance that. But you never want to lose sight that you want to be respected in the community, a high quality provider, and seen as a community leader when things like COVID and others hit. When COVID hit, we opened the largest mass vaccination center in South Texas, and we vaccinated over 600,000 people in a mall that had been closed in San Antonio. That went to a lot of goodwill in the community, that they saw University Health as the leader and stepping up in the community. And I think those types of things get a lot of special recognition. When patients need other services, they know that University Health is for them.
Yeah, I think that's great insight. I think especially right now with the way healthcare and hospitals are viewed, I think it's as important as ever to ensure that you're serving your community. And but sometimes, as you said, you got to make those tough choices. Switching gears a little bit, I want to get into technology and its role in M&A strategy. Of course, we're very just across the board a digital-driven world now. Technology may be a little bit slower compared to some of the other industries in adopting some of that change. But when you're pursuing M&A, how do you ensure that these merged entities are advancing digital health solutions? Ed, why don't you start us off on this one?
Well, I think the things that we've noticed, and again, we're not into the necessarily as much of the hospital acquisitions, but more of the ambulatory practices type thing, is we see that most of the people that we're acquiring don't have the capital to invest in the future. They might have a very okay EMR. They don't have the abilities to take on a lot of AI or technology that can do their documentation, to say that Epic can provide with voice recognition and other services. So what we've seen is that we've really invested into, let's utilize as much of our EMR as we can to the full extent. So if there's something out there that Epic rolls out, we want to be one of the first ones to do it. And we try doing that all the time. That when we go and take over a practice or a dialysis center or a freestanding emergency room really has helped us, because they see that they don't have the dollars to invest in that. I think the downside of that is sometimes that it comes back to hurt you, because some of physician practices in small places don't necessarily follow the rules of electronic medical record to the total completion of Joint Commission and the others, so that they get a little shock when they see that some of the things they have to do. But we supplement that with whatever we can from a technology or say from a staffing standpoint to help them understand that what we can do. We're using AI now in all of our physician reading, in our mammographies, and in our diagnostics. We have a lot of equipment now that is helping the physicians be more efficient and helping them do diagnostic reads, not only in radiology, but in our colonoscopy suites and some of our equipment in the operating room, from robotics to even floor cleaning and others. We've got robots and others taking care of the hospitals. So we're trying to use everything we can to help While it might be a little expensive now, we know in the long run that's not going to be, it'll be a better solution going forward. We think the younger trained physicians, because we have over 600 residents in our hospital, those are the ones that are going to be much more adaptive to using the technology and being more efficient when it comes down to that. So, those things from my chart and getting the patient included, we do now for what we call, it's social determinants of health, but in Texas we call them non-medical drivers of health. We are making sure that they have all access to all of the social services and other services that are available if they need them through a digital platform. For the people that don't have the platform, we're able to, with grants and others, be able to get certain parts of the community with hotspots and others where where the digital divide is. So we see that a big push for our county now is to get the county completely covered with the opportunity to have the internet and others. And we see that as an opportunity to take the underserved and really get them using some digital help solutions to help them with the disease processes as well.
Yeah, and Matt, you had talked about earlier getting everybody on Epic after a merger. What are some other ways, in your opinion, can organizations really ensure that technology is being driven home afterwards?
I would say, interestingly, Epic, when it first came out, was very customized. And a lot of organizations that say they're on one platform of Epic have actually multiple versions of Epic. So I think people's clarity about what are they on and their clarity about how fully maximized that system is really the devil's in the details when you start asking questions. So Ed's point, I think, is very well taken, is when you get Epic in, you want to get the latest version in and you want to maximize that platform. And when you have any future partner, you want to get them on as fast as you can, and you want them to be on the maximized version of that platform. We also believe that you want to do that for your operating structure platform for HR, finance, and supply chain. So we have two chassis that we put in place, Infor and Epic, and we've got the latest versions, and we're maximizing those platforms. And we have a rule that if the platforms can't do what we need, we might buy an add-on that has to be able to plug into that platform, and it has to be a leading plug-in. But as soon as that platform creates an alternative that's as good or close to that, we take that node off and we reduce it and we don't use it and we go back to the platform. So Epic is great at when everybody starts trying to add on to their Epic system. If Epic finds that to be a value, Epic is going to build it into their system eventually, and that operating node, as we call it, or outside software is not necessary, and we can eliminate it. That makes things easier to keep up to date, and that makes it easier when you get an acquisition or a partner to bring them on your structures and your systems, because you're on a very simplified platform and structure as much as you possibly can be, instead of having hundreds and hundreds and hundreds of small little operating platforms that you're working from. And historically, healthcare has done that. We're getting better at that, but historically, we've done that. Finally, I think we're probably so focused on the platform right now, we're not getting what we would call overly involved in all the extraneous IT things that people are talking about today. So I'll just use one. AI is the hot button everybody's talking about. We are like, AI is going to help us, but it's going to help us 10 years from now. It is not going to help us significantly enough today. It's going to take 10 years, just like when we first came out with some of the internet changes in the 90s. It took years before those changes are what they are today. So what we want to do is get our platforms tight, and we want to get them right, and we want to keep them upgraded. And the minute we have an acquisition or a partner, we want to get them on those structures. And then we want to be a fast follower as those other capabilities like AI start to mature more. But we don't necessarily spend our energy and time on going off into those areas at this point, given the diversion that it creates.
Great. We have about 10 minutes left in our session, and I want to ensure that we make sure we have enough time to get to listener questions. So thank you both for a great discussion. That was excellent. This now brings us to the Q&A portion of the program. So we would like to invite you now to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. So first question we have here that I'll throw to you, Ed, first, is what expertise are you finding you don't have or need to pursue to successfully integrate into your system right now?
I think the thing that I would say that right now is because we are a public hospital system, we have a lot of people that have grown up and have become great leaders in our organization, but they haven't worked in a lot of other organizations. Before I came here, when I was hired, I was one of the few outside positions that was hired as the chief operating officer. And I would say very, very good people we have, but what we need to do in healthcare, because it is so different than just running, say, a hospital and you're taking care of patients, but now in the senior leadership role, we need a lot more diversity. Diversity in just where they've worked, diversity from ideas and thinkings and abilities. So I would say that's the one thing that I would say that we're finding that we need more of, is not someone who says this is the way we've done it, this is the way it's been done. In HR and in marketing and in business development and the others, we're always looking to say, okay, where can we get in some new talent with some new ideas, some new thinking, new ways that it could be done.
And Matt, I'll throw the same question your way. What expertise would you be wanting to add that you feel maybe Aspirus doesn't right now have at the moment?
I would say the challenge that we're facing is if you are seeing the environment we see, and some organizations don't see it, and some of those organizations are potentially larger, and people are growing up in those organizations with jobs that are changing dramatically, where certain authorities now are being put into the corporate structure. What I'm finding is that we're either getting talent that isn't fully developed from the perspective of they have learned to do a variety of the things, like for instance, in HR, for instance, in operations or finance. A CFO nowadays in a regional site is not a CFO of a system in the same roles and responsibilities and expectations. Now, when you had a holding company model, that might have been the case. But now, as you have more integrated systems, you have people growing up in finance and HR and operations with less responsibilities than they used to have. So therefore, certain elements aren't getting developed. And then you throw in, if you come from an environment where, say, I hate to say it, but I'll say it this way, somewhat mediocrity is okay. You know what, if we make a small margin of 1 or 2%, we're doing good, we're done. In our world, we expect to make 3 to 4% minimum, because this environment we're talking about could wipe out 3% in a heartbeat if we have another spike in inflation. So if you come from an environment that doesn't have that push to excel, you might come to our organization and say, whoa, that's a little bit more of a push than I'm used to. Why? So we're finding that level of understanding and knowledge, and that level of sometimes of intensity and need to make change happen isn't out there as readily as we would like, and makes it harder to find that type of right fit.
Yeah, great question, that one. I have another good one here. Someone asks, as of today, should healthcare reform focus more on the payer side, or is there more that providers can do to start mitigating the increasing cost of healthcare? Matt, do you want to take this one first?
Yes, I would say the underlying problem that never gets spoken, and I was told this 25, 30 years ago, is America is unhealthy. America has higher obesity rates and higher unhealthiness in its population from the start of our children. In that environment, you have to fix the culture of what we think healthy is in our country. And it can't just be taking a drug to solve obesity. We got to work on our underlying health structures. When you go to many other countries we keep comparing ourselves to, they have a far healthier population. And they also do a far better end-of-life care program than in America. In America, and I know when my day comes, I'm going to be that person who says, give me everything you got. I want to stay alive. But in some countries, that's just not acceptable. So we have an underlying fundamental problem, I think, that's at the baseline of the challenges in our country. Then I believe when you look at the care that needs to be delivered, I would say I'd be apolitical and say all parties have to contribute to improving the cost of healthcare. Providers do, the pharmaceutical industry does, the insurance industry does, and I believe we don't have anywhere near the time to answer how each of us could contribute to reducing costs of care and the waste in healthcare. But I would just put it on us all, and we have to own our piece, just like each of those individuals have to own their piece to improving the cost of healthcare. But I also am a strong proponent of improving the health of our country, because I believe if we do that, that also is a good foundation for us to reduce cost of care too.
Great insight. Ed, I'll ask you the same thing. Where should that reform focus on, payer side or provider side?
Well, I mean, I think, again, Matt hit it, the payer side, we have to take the complication of the payer, and if you could streamline that. I mean, I can speak for, and I think most hospitals do this. It really hurts when you have to hire more billing people and authorization people than to say, I could spend that money and put one more nurse on the floor. So I do know that the system is extremely complicated and we should make it simpler. But we also have to look at, as was said earlier, there's a lot of things that are being done because they can be done. You walk into the doctor and the doctor says, you twisted your knee, and the patient wants an MRI and will continue to ask the doctor for the MRI when the doctor knows we probably don't need to do an MRI right now because you just hurt your knee about a week ago. But they watched the football game yesterday and the star quarterback gets out and knows that the star quarterback's getting a MRI on Monday morning. Well, he's the thoroughbred, you're not. And those types of things. So I think Americans, as well as a lot of people in other countries, they want their health care, they want it now. So when we look at some of these things, it's the easy button. I think you're still afraid of legal. And if doctors are still scared in the emergency room that if they don't do every test in the emergency room, they're going to get sued because something was missed. And so I do think there's a side of where the payers can make this a little more efficient, but we also have to take out the legal side of this, and every doctor that keeps a patient in the hospital 2 more days or addresses every issue in the hospital versus what can be done as an ambulatory side also adds to the cost of healthcare. And especially if we're paid on a fixed DRG and a person comes in here for a total hip, but also gets tests in the hospital for some other ailments, we're only getting paid for that total hip and not those other diagnostics that are getting done. So I think it's an equal balance that it takes everybody working on it. I don't think that anyone can blame. I can't blame Big Pharma. Big Pharma spends billions of dollars to develop a new drug. Well, they want to get their drug costs back. But do they take advantage and charge too much for drugs and those things? So I think every organization that touches healthcare has an opportunity to really look at that and say, what are the things that you can do? And you just can't look at it in an individual bubble, but you got to look at it as a whole.
Great. Great answers, great questions from the listeners. That's all the time we do have for today. In closing, please note that next week's program will cover the winning edge for defeating denials. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week as we cover the topic of M&A on our website. at healthleadersmedia.com. And thank you again to Matt and Ed for a great discussion. We really appreciate it.
Thanks.
Thank you.